Welcome to today's MESUD Learning Community webinar. Today we'll be hearing from Dr. Leah Bauer and Wyman on contingency management and overview of our implementation at MaineHealth. My name is Bethany with CCSME and I'll be supporting today's webinar. Just a few quick notes before I begin. First, neither the presenters nor the planners have any relevant financial relationships to disclose. This activity has been planned and implemented in accordance with the accreditation requirements and policies of the ACCME through a joint providership of the Hanley Center for Health Leadership and Education and CCSME. The Hanley Center is accredited by the MMA Committee on Continuing Medical Education and Accreditation to provide CME for physicians. The Hanley Center has designated this activity for one AMA PRA Category 1 credit. The opinions expressed by the speakers in this webinar series are their own and do not represent the positions of CCSME or the state of Maine. Recording and live stream transmission of this webinar without consent is not permitted. We'll have a few minutes at the end of the presentation for questions and answers, so please hold your questions until that time, or you can place them in the chat. And now I'd like to give a quick introduction to our speakers today. Dr. Leah Bauer is the Medical Director of Behavioral Health at MaineHealth's Behavioral Health and Midcoast Hospital in Brunswick, Maine. She is a Clinical Assistant Professor of Psychiatry at Tufts University School of Medicine and is board certified in Adult Psychiatry and Addiction Medicine. Wyman is a clinical social worker with an extensive background in working with adults who struggle with a series of persistent mental illnesses and addiction disorders. Her clinical work includes crisis intervention, therapy for adults with psychosis, and substance use disorder counseling. Currently, Christine is the clinical director at MaineHealth Behavioral Health's Comprehensive Addiction Psychiatry Services in Brunswick. And with that, I will hand it off to Dr. Bauer and Christine for our presentation. Thank you all for being here today.
All right. Thank you, Bethany, for the introduction. Welcome, everybody. Good afternoon. Thanks for joining us. I'm Leah Bauer. I'm going to kick us off with talking about contingency management for stimulant use disorder. We'll provide an overview of both of those things, and then Christine will talk about the pilot program that we've launched through MaineHealth at Midcoast Hospital over the past 6 months or so. Neither of us have any disclosures to report to you today. So as a means of introduction, stimulant disorder is certainly a growing problem in Maine, as well as in many places across the country. And if you kind of back up and look at this whole substance use disorder epidemic that has been going on now for decades, you can really kind of see a new wave forming, where wave one kind of starting in the early 2000s with prescription opioids becoming a problem, and then people turning to heroin when opioids were more expensive or not as readily available, kind of created this second wave in like the 2010s. And then with fentanyl, the rise of that just over the past handful of years kind of led to this third wave with really huge peaks in mortality of individuals that are using, dying of overdoses. And now we're very much in this fourth wave where there's a whole lot of polysubstance use going on. A lot of folks that are using fentanyl in combination with psychostimulants, which is really kind of contributing to this fourth wave that we're going to be focusing on today. So there's high rates of overdose deaths. That's not news to anybody. It has looked like maybe we've made some traction, and more recent numbers have improved since this peak in 22. But in 2022, 62% of the lethal drug overdoses in Maine did have the involvement of cocaine or methamphetamine in them. I'll just back up to define psychostimulants as cocaine and or methamphetamine or prescription stimulants, by the way. That's what we're kind of talking about in this presentation when we're talking about stimulant use disorder. It's the use of one or all three of those substances, cocaine, methamphetamine, or prescription stimulants. So a large percentage of the overdose deaths were impacted by cocaine or methamphetamine. That's not to say that cocaine or methamphetamine was the cause of death. The vast majority of these deaths were likely caused by fentanyl, but used in combination with cocaine or methamphetamine, either knowingly or kind of surreptitiously. We've been finding clinically that there are a lot of people that are coming in thinking they're using cocaine or thinking they're using amphetamine, and it's really kind of pressed methamphetamine in combination with fentanyl, or people that have had fentanyl showing up in their cocaine. So I think there's a couple of phenomenon going on, folks who are using polysubstances knowingly, and then folks who think they're just using stimulants and then don't really have that opioid tolerance and then are exposed to fentanyl unknowingly and then may die of an overdose. Meanwhile, unlike other substance use disorders like opioid use disorder, where there's good medication treatment options and methadone and buprenorphine, there really isn't any FDA-approved medication that has been beneficial consistently in research for stimulant use disorder. Here's just a blurb from a kind of review of reviews that looked at all of the options over a long period of time, and the evidence really doesn't support any medication in a way that's robust enough to give a formal recommendation to use it. There's some evidence for this or that, for topiramate, for the combination of Wellbutrin and naltrexone, some evidence for psychostimulants, actually for stimulant use disorder, but nothing that has really passed too much muster when you look with a critical lens over the course of many studies. The thing that really has, however, spoiler alert, is contingency management, which we'll talk a lot more about. And that really is kind of the gold standard treatment. Unfortunately, it's not readily available hardly anywhere yet. I'm going to just talk briefly about stimulants for stimulant use disorder because it's a question that always comes up, and thoughts that maybe that would be something that would be helpful kind of in like a substitution way, as some people tend to think about using buprenorphine or methadone for opioid use disorder. So there are quite a few studies that have looked at that, and the results are fairly mixed, and I think need to be interpreted with a good amount of caution. There are some positive studies out there. There's also many studies that aren't positive. The ones that have relatively small kind of benefits and are looking at things in a way that isn't necessarily very consistent with the real world. A lot of them define abstinence as maybe not using cocaine or methamphetamine for like 2 or 3 weeks and then calling that a success. What's been shown to be more helpful is like very, very high doses of psychostimulants, so much so that there might be other risks in patients that have comorbidities, or just to kind of have that kind of stuff out there in society. Many of the trials that have shown success have doses on the order of like 60 to 100 milligrams of amphetamine, or even higher doses of methylphenidate to have any kind of effect on abstinence. What the more consistent outcome for these studies has been in treatment retention, which kind of makes sense. If you're giving somebody a stimulant, they might be more likely to remain in that study, to continue getting that stimulant. But in terms of sustained abstinence over any length of time, there's really very limited data to support the use of psychostimulants for stimulant use disorder. Another factor is that a lot of these populations that they look at are kind of very controlled, without a lot of comorbidities, with mental health disorders or other substance use disorders. And they're kind of screened very carefully and seen in a very frequently and in a very controlled environment that isn't really consistent with kind of real world medical practice. So I think there needs to be a lot more studies and time and analysis of this idea before it's really going to be ready for kind of the mainstream. And ASAM, I was happy to see released a position statement in May of last year that was fairly consistent with that, urging physicians and other prescribers to approach that with a lot of caution, and really only if a physician that has board certification in addiction medicine or psychiatry and has an ability to really maintain a very close level of monitoring of patients, kind of think about that as a treatment plan for a patient. So I'll move on for that. This could be a talk in and of itself and probably would be worth doing, but I just wanted to give that word of caution to all prescribers that are listening. All right, so now around contingency management, which we've shown is really the only thing that really works consistently. I'll try to make that point more clear to you in a second here, but what is CM before we get to that? It's the most effective treatment for stimulant use disorder, and essentially what it is very simple. It's the use of incentives to motivate behavioral change. So when you're looking at this for stimulant use disorder, it generally looks like patients coming into the office, providing a urine drug screen. And if that urine drug screen is negative for stimulants, they receive an incentive in the form of a voucher that has a monetary value associated with it. It's that simple, but in reality, to kind of actually roll it out and go through the whole process of delivering the service, it's proved to be quite complicated. So a little bit more about what CM is. It's really based on the kind of operant conditioning principles of B.F. Skinner that many of you probably learned about in like Psych 101 in college, where animals and humans are motivated by things that are positively reinforced, and punishments are avoided. So in this intervention, it really is the concept of positive reinforcement that is being built upon. So that, when something good is thought to happen, it will reinforce the behavior. And just when you think about SUD and folks in recovery, I think about how little early in recovery, how little positive reinforcement there is. I think, there's negative reinforcement, which is different. And that really means when bad things stop happening, it kind of encourages behavior. And I think there's a lot more of that early in recovery. People, you stop getting into trouble, getting arrested. Family members are more likely to associate with you, but there isn't a lot of like positive things happening for a while for a lot of people that are just entering into recovery. And so I think that's where the power of this intervention really can lie. It kind of can light up that part of the brain that can kind of start that positive feedback from in happening. And we kind of talked about how in the context of stimulant use disorder, CM really means providing an incentive for a negative urine drug screen or another kind of sought upon behavior. And that this has been really shown to have improvement in treatment engagement, retention, as well as outcomes. So there's a couple of methods that are used commonly for contingency management. And if you had to kind of put them in two categories, there's the fishbowl and the voucher method. The fishbowl method is kind of a more gamified version of CM, where patients would kind of literally draw prize slips out of something like a fishbowl. And prize slips may just say, good job, or here's $1, and not have anything super, reinforcing. But there's a chance that you could draw a slip that would get you $100. And the idea would be the further you get in the program and the further you're advancing, you might get more chances to draw out of that fishbowl. With this type of system, it's a little more complicated to implement. There's just more moving parts. But overall, a program can end up spending less per person over time for kind of the same results. The VA has a well-established contingency management program that's been happening for a long time, and they use this method, and then the participants can earn things from the canteen at the VA out of the fishbowl. Our program is using the other method, which is the voucher method, and it's kind of a more straightforward system where there's a known amount to an incentive, and it's predictable how it increases over time in a way that kind of is all laid out for the patient. And so it's just a more kind of a transactional, this urine's negative, where are we at in the program? Okay, you've earned this incentive today, and it kind of increases in value as time goes on with consecutive negative urines. Both methods have been shown to be equally effective in studies, so long as the value of the incentives that one can earn is sufficient. So there's kind of a minimal effective dose for CM, and we'll talk about what that is in a little bit. So what's some of the data behind contingency management? There are over 30 randomized controlled trials out there of CM, and 20 out of 21 of them really showed that abstinence as a primary outcome was statistically significant, that folks were more likely to be abstinent at the conclusion of the intervention. And this efficacy, which was robust, really held up in 7 meta-analyses, kind of comparing all these different trials and taking into account their quality. And there's really a quite large effect size. It's considered a moderate effect size as far as those things go, but compared to what we have in behavioral health, it's a really quite robust effect size of a 0.5. More so than any other psychosocial treatments out there. And so studies generally show that CM patients are about 3 times more likely to be abstinent by the end of the study, and with treatment retention rates around 60%. To kind of put that effect size into context a little bit, if you think about like what is the effect size of the average antidepressant, it's about 0.3. And for CM, it's about 0.5. So it's really more likely to be helpful than like an antidepressant would be for depression. Yet, if somebody was depressed, we'd never not prescribe them an antidepressant because it might not work. You know what I mean? So I like to think about it as if CM were a medication and were shown to be as effective as a medication would be, it would be thought to be very effective, and it would really be the standard of care for stimulant use disorder. One common question is, how do the results hold up long-term kind of after the CM intervention ends? Many studies, there's the time-limited CM, it's, 12 weeks, 24 weeks, something like that. And then the incentives stop. And what happens after that? Are people just going to start using again? That question has been looked at a lot of times, and it's been shown that after that folks are more likely to be abstinent 24 weeks after CM ends compared to patients that were not exposed to the CM intervention in the first place, and that a longer duration of active treatment with CM contributes more to that long-term abstinence. So kind of the longer the intervention, the better outcomes in the long term, even after the intervention stops. Another question is, what about additional psychosocial treatment like CBT, for instance? Does that make CM work better? How does that play in? And that has been looked at. And it's kind of interesting because if you add CBT to CM, it's really been just about as effective as CM alone, which is what that graph on the left shows. It doesn't really have an additive benefit to it. It's not really where the special sauce is. However, if you were to provide CBT as a follow-up to CM after the CM intervention stops, there is benefit there to helping maintain abstinence. So CBT doesn't really help people stop, but it can kind of help them stay stopped after the CM ends, is what the studies show on that. People wonder about cost effectiveness of CM, and I think this question comes up particularly because the monetary value of it is so kind of in your face. When you're saying here's a $10 voucher, is this going to be cost effective? But if you think about how much a medication would cost for a different substance use disorder like opioid use disorder, in 24 weeks of buprenorphine naloxone on GoodRx, and the cash price is about $1,000 for an average dose of that. However, the maximum rewards that most CM programs that you can earn is about $600. That's what our program is. It's $599. And then, the preventive cost of preventing even just one ambulance ride or an ER visit easily kind of easy to make a case that it kind of is certainly worth it cost-wise. So if CM is so great, how come everybody isn't already doing it? I think there's a few reasons there. It's really quite complicated to implement. And part of that is because there's a lot of knowledge deficits out there about what it is and how effective it is. I think these are some of the things that kind of the lay public or folks who are even in the field that aren't familiar with it think, and thoughts that I've even had, before I started learning more. Concerns that CM is kind of like a bribe. Is it kind of manipulative for patients? Is it going to have an adverse effect on motivation to change? Are patients going to then just start using again right after? It's been interesting. I was wondering about that because I think of like my own kids, and a little parenting confession here. Like my kids play piano, and at one point they were not very motivated to sit down and play piano, and I was like, okay, well, I'll give you a gummy bear. Like, sit down and play your songs. And then now it's turned into like, where's my gummy if I'm playing piano? And I was, so it's like, is CM going to be like that? Are people just in it for the cash? And I think we found from the patients that we've had in our program that very much isn't the case. And I think you'll see that later on when we talk kind of more about the patient experience. It just kind of gives them that little boost they need, but people are really motivated beyond what the incentive provides. It's more of like the incentive is like a symbol of their motivation rather than a reason for them to change. There's also concerns with patients maybe like using incentives to purchase more stimulants. You could see certain politicians making arguments like that. In reality, the incentives aren't so high that it's really worth it, I think, for folks to kind of come in and go through the whole rigmarole if they're really not hoping to be abstinent from stimulants. There's easier ways to get $10 if you're, looking to continue using substances. And I think so. I think there's some misconception there. And also I think the big thing is this kind of belief that people don't really like deserve to be rewarded, and I think that's very much rooted more kind of in stigma and bias that, why should folks get money for doing something that they should already not be doing? How is that fair? And I think there's a lot of that sentiment that has kind of slowed the uptake of CM. And like I just said, I think those knowledge deficits really point to kind of stigma as well as a lack of knowledge about SUD and treatment options, and has driven some kind of continuing political resistance to having CM be more funded at federal levels, and that has kind of slowed the acceptance of it. So yeah, there's this lack of funding for incentives. And I'll give you the kind of background on that. Right now, insurances of any kind do not meaningfully fund incentives. There's a $75 per person per year limit on federal funding through Medicaid or Medicare. And that really hasn't shown to be enough of a dose to have meaningful results. All of the studies that have been sponsored by NIDA and so been able to get around those types of caps that have been positive have used at least $500 per person as an effective amount. That's kind of the bottom of the benchmark there. And really, the more money, the better. The better the results. You usually have to have the incentives over a course of a month be like $100 to $200 in order to be sufficiently motivating for folks and have it kind of feel like it's worth their while. Many programs, and ours included, have chose this max of $599 per patient per year because that's the limit of taxable income. Above that, you need to give people tax forms and things like they'd have to file taxes, and there's that whole layer of complexity. So that's kind of where the sweet spot is, and a lot of programs around the country are going with that. The reason, though, that we're able to use that is we're not using federal funding to fund these incentives. We have a grant from MaineHealth, and there's a follow-up grant from a private foundation that we've been able to secure to fund the incentives. They're not being subsidized at all federally. There actually has been a recent development just a couple of weeks ago, which has been exciting. There's been a flurry of advocacy, like right before the new administration took over to try and kind of push some things through. And it did lead to SAMHSA raising the cap from $75 to $750. So that's awesome. That's great. However, it's just on certain funds, and it isn't on what are called block grant funds or funds that are earmarked for Medicaid reimbursement. There are some funds, though, like opioid response funds and also kind of Native American tribe specific funds where this will be able to be rolled out at a more meaningful way. And so it'll be interesting to see how that goes. So I think there will be more options kind of for the state of Maine who do receive some of these opioid response funds to think about incorporating CM, outside of grant funding for incentives. However, there's going to be complications. I think there's some really quite burdensome reporting requirements that are going to be required. And that might kind of slow uptake or make things just a little bit more complex to implement. There's also a process called an 1115 waiver, which gives states kind of an exception to certain rules around how federal funding is used. And some states have successfully navigated that process to allow for insurance, like public insurance funding through Medicaid, to exceed that limit. So that's another route that states can go to kind of get an exception to those federal restrictions. There's also kind of regulatory considerations around kickback laws, and I'll try to talk for just a moment about that. So historically, some programs have been kind of cracked down upon, and I think this has also really slowed CM's uptake. And they were asked to kind of cease and desist because, you're giving kickbacks. You're saying to patients, hey, come in, we'll pay you to be in this program. Isn't that a kickback? And so that question was posed to the Office of Inspector General, and there was this ruling on this safe harbor to the anti-kickback statute, questions around whether CM could be kind of granted a blanket safe harbor for that. And they came back and said, not exactly, it could still be a kickback, but there's ways to do it so that it isn't. And what we're going to do is actually put out these guidelines and guardrails so that you can develop programs and implement them that are within those guidelines and guardrails, and then are therefore not subject to anti-kickback concerns. So those are available, and experts are available to consult with, as CCSME has helped us connect with, to make sure that those guidelines are being observed and that protocols are within line of them. Essentially, there's a way to do this. It's important to have a really clear protocol, and it's important to maintain fidelity to that protocol, or else there could be a theoretical risk of violating anti-kickback statutes. So what are those? It was kind of the brief version of what are those guidelines and guardrails. Essentially, incentives can really only be provided that are recommended by a healthcare provider and that are directly connected to the care of the patient. So it can only be for patients that have stimulant use disorder that meet certain criteria that are set out by the program and that are kind of like formally recommended by a healthcare provider. Also, that incentives are really delivered only when the desired health outcome occurs, and that's where the fidelity to a protocol really is important. So generally for stimulant use disorder, the outcome is a stimulant negative urine drug screen. And so it would not be okay to have a patient that came in and their test was positive, but we know they're really trying, and they said it was a week since they used, and the test shouldn't still be positive, and don't we what they're going to drop out? Maybe we should just give them the incentive. No, like you really have to go with what your protocol says and only incentivize stimulant negative urine drug screens. They do say it's okay to use telehealth and other digital health technology to help implement CM. What is not okay to do in programs is really advertising incentives with the purpose of recruiting patients or swaying them away from other forms of treatment. So we've been having to be careful about that. We can't just hang up signs saying, call us, come in, you'll earn money to not use stimulants. You have to be kind of careful in how you word things, and how you get the word out. It's not okay to use incentives and then jack up fees that patients are paying to come in, or to have some sort of excessive or inappropriate reimbursement come. And then it's also important to have adequate protection against fraud. And we've been very grateful to the state of Maine DHHS for helping us purchase a software product that really comes with a lot of fraud protection built in, and no incentives of value actually stored on site. And then, it does all the math for you. So you can't have somebody in your office, pocketing the gift cards or switching the numbers around so that the math adds up. You have to make sure that there's good kind of checks and balances in place to kind of pass muster. So that's probably more detail than you wanted to know about all the technicalities there, but hopefully it was helpful. And now I'm going to be turning things over to Christine to talk more about CM around the country and what we're doing exactly in Mid-Coast, Maine.
Great, thanks. So as you can see from what Leah presented, there is a lot of interest in CM because there's a lot of need for it. And we see West Virginia is interested in CM. The VA is using it. Washington State is interested. And the state of California has been able to implement really the first statewide program of CM. So our program was modeled closely after the California program. And one thing that I find to be particularly alluring about the California program is that they have been able to implement CM using the 1115 waiver. So they are actually able to use Medicaid dollars to fund the incentives. And this has really helped make this program more mainstream in California, reach more people. And it also gives a lot of data to look at too as we look forward into the future of CM. So as you can see, 166 sites are participating across 24 counties. Individuals can earn up to $599 in value over the course of a 24-week program. So they're presenting twice a week for 12 weeks and once a week for another 12 weeks. And they are using a software supplied through a company called Contingency Management Innovations that it's a software that allows you to give out the incentives and tracks the urines. So our program was modeled very, very closely after this one. Meanwhile, in Maine, we also have another organization who has launched contingency management. Spurwink, as you can see, has launched it. They are also working with CCSME, Dr. Richard Rawson, and funders. They launched it in January of 2024. Their program is slightly different than ours. They use the voucher method, but they do use a different frequency and amount and a different tool for delivering the incentives than our program. And of note, they're also rather urban. They are right in downtown Portland and Bayside. Our programs comparatively are in a more rural location. And so when looking at 9 months of their data, we see that they have a 69% show rate. And of those that show, 87% of the urine drug screens are negative for stimulants. And so what are we doing about CM at MaineHealth? We launched our program at the absolute tail end of May in 2024, really enrolling our first clients at the beginning of June. Our process has been one, it took us about 2 years from the point of recognizing we needed to do something about stimulant use disorder to the point in which we were able to launch the program. And this started with staff really coming together and trying to understand what would be an effective intervention for individuals with stimulant use disorders. That took its own bit of time, a couple of months. And then once we identified that contingency management would really be the best option, we started to go through some concrete steps to see if we could launch it. One of those included going through the IRB to demonstrate it was not research. Then we also began to look at what various funding sources could we tap into. This was the point where we were able to identify and then eventually get the funding from the MaineHealth Innovation Center for the incentives. And we were also able to partner with DHHS to help us fund the software that we're using to deliver the incentives. This planning phase really took about a year. And that at the end of that planning phase was when we were connected to CCSME and Dr. Rawson. And so this is just a nice pictorial representation of really everyone that we have partnered with on an everyday basis to get this to launch. And this, us being able to do this really wouldn't be possible without having this many stakeholders at the table. It truly has been such a team effort. And so as I mentioned before, we had a 2-year process for launching this, and it was kind of, 1 year was divided up almost in like planning, and then the second year was a bit more of the action phase. And so during that, once we realized that we were going to be able to have avenues for funding, we really spent some time identifying who is our target population, what is our admission criteria, which method would we prefer to do for CM, the fishbowl or the vouchers, how are we going to structure the visits. We also, once we were able to get the funding too, or be very likely to get the funding, we needed to start going through some other processes as well. We needed to get our CLIA waivers. We needed to train in doing point of care urine drug testing, get the supplies. We also needed to navigate our own internal legal system to make sure that we had service agreements in place and that everything, that the organization was comfortable with us launching this. And that took its own fair chunk of time. And meanwhile, while we were doing that, we were also really trying to identify how many staff would we need to allocate to a single visit? Would we be able to bill for any of it? We would need to train on the software and identify also some standard operating procedures, because this program is a little bit different than other ones that we've done previously. And so in June of 2024, we were able to finally launch. And I think we enrolled 2 or 3 clients for our first day. And since then, we've had many more involved. And we see the clients twice a week. We continue with monthly coaching calls with CCSME, Dr. Rawson, and the other sites, including Spurwink, who are doing this. We also incorporate a clinical review weekly. So what does our program look like? Generally, clients are identified for participating in the program at the point of intake. And so when they do their intake and it is disclosed that they are either using methamphetamine or cocaine, or they're misusing prescribed stimulants, a clinician will talk to them about wondering if they're interested in participating in this program. We have had some individuals who are clear they do not want to participate, but the vast majority of them are interested in participating. And so once the clinician has had that conversation, it's handed off to really the clinician who is working with the contingency management clients day in and day out. And so that clinician then makes a connection with the client, and they make a plan to usually start them on a Monday, generally. And the client comes in twice a week to give a point of care urine drug screen that produces an immediate result. We do ours on Mondays and Thursdays. The other option would be Tuesday and Friday, but you really want to try and keep the urine drug screens as equidistant from one another within a week as possible, especially when you're considering weekends, because you want to ensure the maximum ability to get the negative result. And so once they give that urine drug screen, the clinician and the client together utilize the incentive software. And the software is really intended to be used with the client to help augment the clinical intervention. So the client is really there with the clinician as they're putting in the results, and the client is seeing the almost like the rings on an Apple Watch close. And then they get to choose where they would like their incentives. The incentives are almost like gift cards, but they are not cash. There's no cash value, and they cannot be used on alcohol, tobacco, firearms, or cannabis. And so the client chooses from a pre-approved list of vendors, and then they can either get it sent to their phone, or if needed, we can print it out for the client. And then during that same visit, they also have a brief psychoeducation. There's psychoeducation with the clinician built into that CM visit. And then they're also encouraged to attend other treatment if desired. And then after 12 weeks, the visits decrease to once a week for another 12 weeks. So the admission criteria is relatively straightforward. We look at individuals who have met the criteria for stimulant use disorder using the DSM-5 for the past 12 months. If there's someone referred who has been in a controlled environment during that time, for example, a hospital, or they were incarcerated, we would want to ensure that they met criteria for symptoms prior to that being in that controlled environment. The client also has to want to engage in CM and be abstinent. As I mentioned before, there have been individuals who we have shared this program with and offered it to them, and they have declined, citing that they aren't interested at this time. And the client does need to be able to come in twice a week for the urine drug screens. I'm not off the top of my head aware of any individuals where this has been a barrier. However, that is for us a consideration. And patients can't be prescribed stimulants for another condition. Otherwise, the urine drug screen, you're never really going to be able to tell. So this is a nice pictorial representation of the software that we're using through the company Contingency Management Innovations. And what you're seeing here is, this is a fake client, but you're seeing that to the left of the screen that they're entering in the urine drug screen result. And you can see that they are slowly increasing in value over time, but then decrease momentarily when someone either misses or has a positive urine drug screen. And then on the left-hand side, you can see sort of the receipt, if you will, of where the person had asked their gift cards to be sent to. The individual can bank their incentives if desired or cash them out immediately. It is generally considered better to not bank them because you want to encourage that immediate reward, and banking them doesn't always necessarily give that. The benefit to this is that we're not storing items of value on site. There's nothing that we have to worry about being stolen. We don't have to worry about the accounting. It also, we don't have to dedicate staffing to monitoring these incentives. They're also, as I mentioned before, they're protected. They can't be used on certain items, which, at least for launching this within our organization, that was something that was a consideration. And the software is intended to be used with the client, as I mentioned before, to really augment the clinical intervention. This here is a picture of our incentive ladder. This is something that we do make available to the clients enrolled so they can understand how much they can earn. The incentive ladder that you're seeing is it's for all 24 weeks, and it is based on the assumption that every urine is a negative one. So if they have a positive urine or miss, then they would not earn the total value of the $599. But this is something we like to apprise people of, so that way they're aware of what the structure would look like and how much they could earn. So the trust model, this is something that Dr. Richard Rawson and some others created in response to, I believe it was the state of West Virginia, wanting some psychosocial interventions that were targeted to CM. And this is a model that is based on CBT, as well as the community reinforcement approach and motivational interviewing, to help provide a nice psychosocial intervention to CM. This is something we draw on these materials for when we do the psychoeducation in our visits with clients. However, we're not necessarily using every form from this in every intervention. It's kind of depending on the client as to what's really needed in that time. And so what does our data show? So as you can see here, we serve clients coming from a wide variety of areas. Currently, or to date, we have served individuals coming from 10 different towns, coming from potentially an hour away in some instances. And so as you can really see, we're serving a rural community. Many people coming from rural areas. There are currently, or to date, we see that 50% of our enrolled clients receive a buprenorphine product. And 77% of our clients receive additional substance use disorder treatment. And of those 77%, we see that almost 60%, 59%, receive some form of medications for substance use disorders, but that includes individuals who might be prescribed a medication for alcohol use disorder. Another 41% participate in IOP, and just 4.5% do the outpatient level of care. And so when looking at the overall UDS results, we count absences as positive urine drug screens. And this is in line with the research that has been done and how the state of California is doing this too. And so we see that currently, for the data we have to date, 66% of the urine drug screens are negative for stimulants. 34% have been positive. The total incentives earned to date are $2,955. Meanwhile, we see our attendance rate is 77% of those attend. And of those that attend, we're seeing that 85.5% of those urine drug screens are negative for stimulants. So when we break the data down this way, we can see that it correlates nicely with the data that Spurwink is getting to. And so we did take the opportunity to ask some clients about what do they think about this so far? And we see that some are saying that it's easy to do. They don't need to spend lengthy periods of time here in treatment, and they don't have to worry about childcare as much. Some are saying that even though the value of the incentive is relatively low, it doesn't matter to them. It's more important to prove that they can do it. Others report that the relationship with the clinicians is very important. The encouragement that is given and really showing the strength that they can do it. And once again, another one just saying like, it's not that much money, but there's just something about it. Meanwhile, staff are also reporting that they feel that this is really a helpful intervention to be able to provide. They say they're identifying that it's positive and recovery-based and evidence-based, and it really just provides them something meaningful that they can give as an intervention for individuals who are struggling with stimulant use disorder that they really weren't able to do previously. And that was very disengaging for people. And so what's next? So we have some, I guess, almost like sister locations with MaineHealth, these comprehensive addiction medicine programs. And they have both now launched contingency management in Portland and Norway, and they're well underway. And funding has been secured through a private foundation to continue covering the incentives through 2026. And we hope to continue to partner with DHHS as it relates to spreading this model further wide after. Thank you.
Thank you both so much. I do see that there are a couple questions in the chat. Edward wanted to know if contingency management is effective for other SUDs.
I can take that. Yes, it is. There is definitely good evidence to support it for nicotine use disorder, for tobacco. There's definitely programs out there that do that. For cannabis use disorder, it can be hard because one thing that stimulant use disorder makes it's just so perfect for is, number one, there aren't really any other options that work with medications or other forms of therapy, but also because the detection window of stimulants is relatively short. And so you can reasonably, think that somebody can come in and test negative, and that means they haven't used in the past few days. It can be harder for cannabis because it can be detected for long periods of time, up to a month or more for folks that are using regularly. And so they can be coming in and saying, I'm not using, and still testing positive. So, but there's some modified protocols out there for that. I think CM also can be used, not just using urine drug screens as the kind of target behavior, but in other ways. The whole kind of principle behind using contingency management is definitely used in other substance use disorders. But I think for the reasons I just explained, it's really kind of taking off more for stimulant use disorder.
Edward also had a question about, so CM is considered to be evidence-based for treatment for SUDs.
Yeah, absolutely. There's a really strong base of evidence for it.
Bianca wanted to know, can any vendor within reason choose to enroll as one of the vendors for CM, or is there a selection process for that as well?
So as doing this, the vendor would need to have a relationship with the company like Contingency Management Innovations. I do think, though, that the big sticking point is the vendor would need to be agreeable to having a restricted gift card given, and that this has been the sticking point for some people either being able to be on the list or not.
James wanted to know, does your point of care UDSs include fentanyl or any difficulties getting those covered by CLIA?
Yes, good question. There is a new point of care test that's CLIA waived that includes fentanyl on a point of care cup, and we are now using that. It is just kind of hot off the presses in the past 6 months or so, and we kind of just happened to find it online, and we're able to order that and get it all built into our EMR and stuff, and is now being used just as of very recently. So really glad to hear that that's an option now. That had been a big gap without any kind of FDA approved or CLIA approved rather, or I guess it is FDA approved for fentanyl. People were using these kind of like self test strips, but there wasn't anything that was really vetted until very recently. And no, that's not true.
If there's any other questions, please place them in chat. Natalie was said, interesting about POC. Thank you for all of this info. I have a question for both of you. What question did you hope to get asked today?
I'll think on that. I'm sorry, I'm typing something into the chat about the cup, but let me think. I can think about that if anyone has any other questions.
And James shares that CM has been used for alcohol use disorder in Native American populations. That would be interesting to see how those rates compared to what you guys are experiencing.
I hope maybe someone can ask, how can I get my patient into this program? And so we are very much accepting new clients. We'd welcome anybody who particularly is living in the Mid-Coast region to reach out to our locations in Brunswick or Damariscotta, and we could easily hook them right into this. We got money in the bank. Yeah, I think what we're finding is that it's hard in a rural setting for folks to be able to commit to this. And it's also hard with our current just kind of staffing shortages across the field to be able to offer this over lengthy windows of time, to have like a clinician freed up for a patient to drop in at any time on Monday or Thursday. We'd love to be able to offer that, but it's not realistic with our current staffing. But we're very much accepting new clients. So I can put our contact information in the chat if anyone's working with anybody who would benefit.
Be great. Felicia wants to know, is there a specific referral for CM?
We do not have one that is specific to contingency management. Ultimately, if people can either refer, like a provider can refer someone, for example, like through Epic or something, or alternatively, we really welcome self-referrals. And if individuals just exactly as Leah put in the chat, just call us at 373-6950, and we're happy to help get them started. Now, someone had also put another question in the chat around the barriers to CM. And so I think transportation is certainly one barrier. It's probably a very significant barrier. I think something that would be almost like an ideal solution would be to be able to be mobile, to take the program closer to where people are living or working. As people will report that it's either transportation or their work schedules. And I think those things really seem to kind of come together. And so being able to be mobile would be something that I think would really help clients the most.
Yeah, or some sort of hybrid or telehealth option. I think a barrier there is saliva-based point of care testing. I think there is some technology around that, but it isn't super readily available, and I'm not sure how good it is. Or some kind of, where you go somewhere else for the test or something. I don't know, but I think that there could be some modified protocols that involve televideo to some extent.
Yeah, do you think there could be an online option? So yeah, I think you've already addressed that. Yeah, and Danielle shared that telehealth is great for rural settings. Any other questions can be placed in chat. And if you think of a question later, you can always email me and I will pass it on to Dr. Bauer and Christine. That is all the questions we have. I will give you 2 minutes back in your hour. Thank you both for presenting today. It was wonderful information, and thank you all for being here today. Hope to see you again soon.